No, it's like, Stephen would expect, hey, question, response. But are we ready? Are we good?
Ready.
All right. So Kelly's now going to lead us through the confirmation consensus and then into the solutions piece. Some people have described it. Do you guys call it the 3-meeting model in a way? Because some people talk about that. The first meeting is kind of, getting all the facts figured out, doing all that, and then the next meeting is confirmation consensus, and then the next meeting is solutions. Versus what I used to see in the old day was, you did it all in one meeting, for God's sake. Well, no, horribly inefficient, which is why most of our process improvements were, we're going to write a policy, and we're going to have an in-service. And the Joint Commission was very happy with that when we did that. But Kelly's now going to lead us through that. While we're doing this, have on your little piece of paper, be thinking about, what are you going to tell the sons of the woman who died when you meet, coming up? We'll go through what the details of that. But think about that, because you're going to learn a lot of information there. And remember, what did we learn in the last workshop? What do patients and families want after unexpected harm? The 3 buckets. This was on your quiz. I think most of you got the answer to this right. What are the big 3? So they want emotional first aid, they want an apology, they want empathy, they want that piece, the emotion piece. What are the 2 big things do they want? They want an open and honest, factual description of what happened at a level they can understand. And the last one I think I heard you mention, which is the whole point of this, which is, what are you going to do to prevent in the future? In other words, don't abandon me. Keep talking to me. As you learn more, you share more. And if, in fact, you do identify things, what are you going to do? And maybe even consider, can I be part of it? That's what I love about what, Stephen does when he goes out there. Shares so much of that. So I'll let you go,
okay.
Kelly. And okay. You've got the slide advancer?
I've got the clicker.
Perfect.
I don't have many slides now because we're just mostly going to discuss. But so just to orient us, we've finished our event review. We interviewed people, we reviewed documents, we observed the floor, we talked to other people who have done this kind of thing. We did our entire event review. Now we want to bring people together and come to some consensus about what we think contributed to this event. So at your confirmation and consensus meeting, you'll want to have your core team. You'll want to have the people who did the event review and other stakeholders. It might be risk managers. It might be department chairs. It might be patients and families. Anyone who has a stake that you want to include, that's great. It is not a review of the event. You've done the review. And this is a departure from more traditional root cause analysis where you're sitting in the room doing the review. The review is done. Now you're coming to consensus on what caused the event. So that's really the only slide I have. Now let's just talk about our case and what we think contributed to the event. We had some notes. I don't know if we want to start with the notes or we can start blank. Where's our box?
I think we could start de novo, whiteboard here. They've had a chance to think about it. We wrote some of their other thoughts before, but now let's do it kind of in an organized, systematic way as we pull together the contributory causes. Yep.
It was almost a perfect storm. I mean, you had so many factors in place that probably if one were not in place, things would have gotten better. But it was an anticoagulated patient that was being catheter was being removed prematurely. That's one.
So sort of an unknown anticoagulation that wasn't communicated or known by all the team who needed to know it.
It was implied by suggesting that it be removed the next day, so it's implied.
Yeah, but not implicit. Yeah.
Well, and you said that wasn't in the record. That wasn't in the record when the line was pulled. It wasn't put in
the note got added to not pull the line after the line was pulled.
So ineffective handoff, that's good.
Wonderful.
So
Ineffective handoff. Sorry.
Both the nurse and the physician involved were inexperienced or had limited experience with the procedure.
That's great.
Yep.
No protocol.
So, for sure. For pulling lines. All right. And inexperienced clinicians.
And then if we can also go back to the first comment that you made, they didn't have, when you said an anticoagulant patient, unknown, so that the provider didn't have, it wasn't just the handoff, the provider didn't have the information available to them that they needed.
Mm-hmm. So how might you more clearly kind of drill down on what that cause
Sort
was?
of incomplete medical record.
Well, so yeah, I mean so there clearly is an EMR medical record issue,
Right.
Related to a communication, certainly a communication opportunities in EMR.
Yeah, specific to the,
Yeah, specific to the EMR.
yeah.
I was just wondering, because she's had heparin how many days, did he not look at any of the medical records to see she's on heparin one day, heparin again, and then he could have followed up more to see did she have heparin that day?
Well, the heparin comes with plasmapheresis.
Right, but didn't she have it numerous days in a row, and this was the last
Not
day?
in a row. Remember, it was every other day. So that's in there, plasmapheresis. Every other day, she gets heparinized, gets plasmapheresis. They allow it to,
Gotcha.
it never gets reversed.
But he could have seen this was going on and did a little bit more research.
Yeah.
Maybe.
Well, and then maybe that points to production pressures. There was pressure to,
Yeah, absolutely production pressures.
Get her done, get her done, get her done.
right, just pressure
Get her
to-
out of the hospital, so pull the line now so she can go out first thing tomorrow morning instead of wait till tomorrow morning and then pull it out and so you get the bed earlier. If there was no complication, that bed's open in the morning as soon as she leaves at 7 o'clock. Yep.
staffing.
So these are all, maybe I'll tear these off after this and we
Okay,
get into the
okay.
solutions piece. So staffing issues. Do you have a slide where Kelly lists the buckets of stuff? What's that? No, the buckets of stuff. Like she goes
So
through the
task
Yep.
care processes. I'll read off some of my list for you. I will
because
go
there's
grab
a
those.
whole lot she
Environmental.
went through ahead of time.
Yeah.
Yes. Tuck it in? Oh, yeah, okay.
I would say an actual process for getting assistance when you're going to do a procedure.
Yeah.
What's that?
The process for getting assistance. Getting that pulling a nurse.
Yeah,
Either
so
on
you could paraphrase that into neither of them feeling quite comfortable calling for help. I mean, so there's the culture piece where they had a good relationship, but they didn't feel it. But are you saying there wasn't a system to call for help?
Maybe like a support insufficiency of some type.
What's
So
that?
Oh, so I thought where you were going was just this was a nurse that didn't know the patient, didn't know, it's just because they had a relationship with the,
I was
Physician.
thinking that neither of them knew the patient. I mean,
right.
it didn't sound like they knew the patient very well. I mean, they didn't, record was incomplete, whether it was looked at or not. I mean, it wasn't either one of them's patient. You know what I mean? So they
Yeah.
didn't know the patient.
How did the two of them end up being the ones to pull the
Exactly.
line when,
Okay, so remember when Kelly talked about it, you need to show that what you're sharing is totally true, and it's super unfortunate. But what we want to be able to do is take what you said and explain how that caused the harm. In other words, all these things that we go through, staffing issue, did it cause the harm? Contributed? Sure it did. You know, because you've got people going in, they're rushed, they're hurried,
Well, and the
the
fact
nurse
that
has to run away.
got paged away.
The nurse
and-
gets paged away. That's how it causes. You go to the other, think about this, because this is kind of the legal thing. How did the ineffective handoff contribute to the harm? Well, the issue related to heparin didn't get communicated, and so the line got pulled out earlier than it did. No protocol for pulling lines, huge, right? You know, in terms of there wasn't protocol saying the nurse has got to stay for 10 minutes, you know, with the doc or what have you. Inexperienced clinicians, you know, led to them to be doing things in a way that otherwise they wouldn't do. And again, this communication opportunities with heparin we talked about. And again, the production pressures, which is all this stuff coming in. Oh my God, we need beds. And in that process of doing that. So going back to what you mentioned, again, think through each of these, how they caused, or part of caused, you know, contributed to what the harm event was.
We also had some equipment issues. We had some equipment issues, I think, where we didn't have enough of the gauze pads or the 4x4s opened for the
Right.
procedure.
So one way to kind of look at the opportunity, how would you put that on the equipment side? How would you kind of phrase that in the positive? So, because I agree with you.
It might be a care process because we actually had the gauze pads there. We just didn't have,
they weren't prepped.
they weren't open and available for use when needed. To open them as, yeah. So it could be a care process issue. I don't know.
Yeah, so I agree on the care process. The other part is, although it didn't come out here, is there might be an opportunity to create a standardized packet for pulling lines out, so you don't have to run around and get all that stuff. And then,
A checklist with a kit.
yep. So,
Now,
yeah.
that we're going to solution, sort of.
Yeah,
But we're-
but one of the contributory issues was there wasn't a standardized process for the equipment or the protocol. So lack of that.
So
Right.
that's procedural clarity. There was lack
Yeah.
of clarity.
Lack of procedural clarity?
Yeah.
Okay, yep.
And then I think the other piece of it is, I'm not exactly sure how to word this, but I want my staff to know what they're competent and
Oh,
what,
God.
and able to do. So their scope of practice and competency, we need to
Right.
define that. A nurse shouldn't pull a line if she isn't competent to do so.
And take that a little further, I think you're absolutely right. And in the real case, this was the other piece of it is, and I would just ask particularly those of you in here, how do you know whether or not this physician is competent to pull that line out?
You don't.
That's right. Right? You don't.
Yeah,
And
it's
so
a
that's
system
a
failure.
huge contributor. We don't have a methodology to ensure that the nurses and the doctors are competent.
So how we would combat that? I mean, it's a system failure because the culture is not, fair and just, so they don't feel that they have the ability to speak up
Right.
and stop and
Right.
go get somebody, or we call it stop and resolve. So, a patient safety technique to use when they get into a situation where they don't feel comfortable. So to me, that's like a system failure with their culture, that they don't feel comfortable enough to speak up and say, wait a minute, I've never
Right.
done this before. Let me get somebody to help.
So asking a couple more whys, why were the clinicians not competent?
Well, for one, the nurse wasn't even, she was I thought we said the nurse was a psychiatric nurse.
No, in the real case, it was a psych intern
Psych
who was
intern.
on the service.
Okay, sorry.
But no,
Lots of details.
so keep going on the. This is going with Kelly. Ask a few more whys
Uh-huh.
to see what some of those contributory causes were. Why weren't they competent? Why is anybody not competent at doing a procedure? Yeah, they haven't been trained. There was no training. There was zero training in the organization for pulling lines out. No training protocol related to it. So
And no measure of competency.
that's right. So there's no competency and no measure of it, and no repository for people to be able to go into to know, hey, is this person rotating up or is this nurse competent to pull it out? So there's a training issue that's in here, true, related to the competency. There wasn't any at the time for pulling lines out.
Yeah.
I'd like this sidebar thought to go along with that. Back to being task-oriented and just getting things done, it kind of does go back to culture again with what is your culture? Are you going to have a nurse that says, stop, I'm not competent, or says, sure, I can go in there and help you, even though they're not?
Yep.
And then, yeah, you get into that conversation. So, I mean...
So that kind of goes, again, back, so how would you, it's kind of the not calling for help, but it's also the comfort level of being able to speak up to say, I'm not comfortable doing this.
And I think I would be careful calling it reckless. It's more at risk. It wasn't an intentional.
Because they are,
But it was-
remember, they're unconsciously incompetent.
Yeah.
Because the nurse said, I liked his energy, I liked him, I just wanted to go help. And I think, like, that's all as nurses, we just want to help each other.
Right.
Get stuff done and do the best we can, but
Sure.
you need people in a culture that says, stop, I'm not competent in that, I can't do that.
I completely agree. I'm trying to,
But
how
it's
would
a
you
really hard
phrase
thing to
that?
do. It's a-
How
I
would you
know.
phrase that as a, it's a communication bucket piece, you know, it's a communication, how would you phrase that? Because I don't want to jump ahead too fast, because I'm thinking about what the solution potentially is for that. I'm just trying to make sure we're helping you see there's these different steps. Do the review with all of now what you have, identify contributory causes so it can help you lead to solutions. How would you phrase that?
So from that nurse's standpoint then, was it a lack of awareness of her resources in going up the chain of command if she felt like she was asked to participate in a procedure she was inexperienced in? I mean, was it clear who she could go to?
But remember, she's unconsciously incompetent, and so
Right.
she
So she
doesn't
doesn't even
know,
recognize she's
she
in
doesn't,
over her head.
she's not feeling, he feels a little more pressure to do it, kind of feels put upon about the rest of it. That's an issue with him we can talk about, which is the chain of command in medicine
Yes.
of how do we make sure that that happens here.
The nurse probably assumed that he knew what he was doing.
Of course.
Right.
We're just gonna sit. How many times have we been in that position?
So, do you ever use assumption as a contributory cause? Because you're kind of right. I mean, all these assumptions were made. There was no real process to validate that assumption. You know what assumption means, right? If we assume things, right? But I mean, would you?
But I think it was an environment of mutual trust and respect. I think you were working in an environment of mutual trust and respect, and so the nurse liked the physician, and the physician liked the nurse. They'd worked together before, had good energy, you know, positive vibe, however they described it, but a good working relationship. And so I think sometimes that is a contributing factor, is just simply the trust that you have with each other may lead you to walk down a path that, in fact,
Maybe
might
some
be,
complacency almost.
yeah,
that-
yeah, almost.
Okay, I like
Complacency's
that.
good. That's
Complacency.
Yep.
Nice. As certainly a contributory cause.
It's not easy to spell in front of people.
No, it's not either. And it's probably all wrong too, but.
Oh, I had a list. We can run down my demands of the task. Was it a period of high workload? Was there time pressure? Was the team in a hurry? Did you have to perform multiple tasks simultaneously or to constantly switch between tasks? Was there clear guidance on what needed to be done? Oh, I skipped, was it a monotonous task? In this case, that doesn't apply. Is there a procedure, and is the procedure available, workable, and routinely used?
No. And I think that gets to what I think, what he mentioned back here. That's this piece here.
Yep. Was the caregiver required to interpret anything, especially anything that wasn't clear or could be interpreted differently by someone else? And then under care process.
And I would say that's where, here, because that note isn't explicit
Right.
about heparin and don't do it for this reason and the rest
Yep.
of it. So
Yep.
different people could assume, like you said, just keep it until tomorrow in case we need to use it. And if the team says, we're not going to need to use this, all of a sudden that
Right.
assumption leads them through.
Well, and even what you brought up earlier about couldn't the physician have seen in the record they've been on heparin every other day for, couldn't they have drawn? But that's, of course, an interpretation that some might make the connection and some might not. Care process. Staffing ratio, we've discussed staffing. What was the patient load like? We didn't really get into that. Was that an issue? Was that,
Well, the patient load and all that?
Yeah.
Well, it sort of did, and I'm thinking about, because it is in my view, it was a big cause. I'm just trying to peel it back to get to why to get what you want, and that is the nurse gets paged away. In other words, there clearly is so much going on that there wasn't the ability to focus on that and make sure they were, so clearly the cause is being not well trained, not knowing it, but then there's so much chaos going on, gets called away. And I think that fits into that. I'm just not sure how to phrase it in a way that's going to help.
It was sort of like competing priorities.
Sure, that's a
Yeah,
good one.
yeah.
Yep, that's a very good one. Competing priorities.
Were any of the involved individuals working extended shifts? Could fatigue have been a factor? I think we established that was not the case here.
Right.
Were there distractions or interruptions? Certainly.
Mm-hmm.
The nurse being called away. Anything out of the ordinary or different from what's usually done? This was a big line.
So I think maybe you're getting to that category. So keep going with that, because there's a category we haven't talked at all about yet that we really uncovered. But I think going systematically like you're doing, Kelly,
Okay.
through that, you're going to hit it. You're going to hit one of them.
Was the staff using any workarounds? I don't think we had workarounds in this case. Okay, let's move to physical environment. Environmental factors like lighting, overhead paging, noise levels, slippery surfaces.
So what do you think about that, the physical piece here? It's not really come up and been talked about.
One of the questions I had in my head earlier was if the nurse got paged away, how loud was it in the room, and does that impact concentration if there are constant pages, noise? And we never asked about that, so I don't know if that might be
Yeah,
part
well,
of
the
it.
process of paging away is more like Vocera, where, hey, I need you to come, and then
Okay.
they leave the room,
Wasn't
versus the overhead page.
Okay.
But I want to go back to this because it was a huge piece in the solutions. Let's think again about the physical environment.
So maybe it'll help if I give an example.
Okay.
I did an event review where nurses were responsible for monitoring some central monitors. But the monitors were physically located not at the nurse's station, but at the physician and PA station. And so they were less likely to hear an alarm. The physicians were not often there, and even when they were there, they knew it was a nurse's responsibility. So they didn't. So just the physical space, how things are laid out, can affect
So in this
what can
case,
happen.
Ryan, the nurse, said he was behind the physician. He described his presence as
Yeah,
being
yeah.
behind the
Yep.
physician.
Yep. So he's behind it, so that is part of it, and then they leave, so isn't able to necessarily see. But I'm going. Oh, so the supplies were in the supply room, so I had to run around, gather all that, put it all, and it was as was described here, it was on one of those bedside tables that you can raise and lower, and you can do that part. Yeah, he did have to yell out, and I don't think inappropriately, because he's holding pressure, and he doesn't want to let go even further to call for hit the code button, so he sees somebody walking by and calls the code. But I want to go a little bit further. What we haven't really, pursued too much is, then the question we didn't ask was, were there any nurses on a neurology floor competent at pulling out a dialysis catheter? And the answer would be no. None of them had ever done that. What issue does that raise on the physical environment piece? Why was that patient there? Well, we know why they're on neurology, but take it a little bit further, which is,
Why was the line pulled?
why is the line being pulled on the neurology floor, right? I mean, this is a huge issue, which is a lot of people agreed and said, because if there is a complication, you now have all these other issues. Hard to call for help, don't have a lot of people around, you don't have monitors up, to be able to do that. The patient wasn't on a monitor, and some would have said, hey, to pull this out, we ought to have monitors. So one of the big contributory causes was inappropriate location for pulling a line. What else would you like to know about the line in the initial phases of it? Would you like to know where it was put in? Or who put it in? Andy, where did the line get put in? Radiology. Which part of radiology? Interventional radiology. Right. Inappropriate. So there are some who would suggest that if IR puts it in, they take it out. Now, I know we're going down the road to the solution piece, but everybody stepped back and agreed, oh my God, why are we doing this procedure on this floor? Because we found out about the competency of that nurse, but you would not have found a nurse on that floor who'd actually been there to pull out a dialysis catheter. It's just not that common for doing that. So that's why I love your list of kind of going through there and thinking outside the box for some of these.
And so then I can move to communication issues, a lot of which we've covered. Do they have access to all information they need in order to make the best decisions? Things like medical record, lab results, images, past medical history, test results. Is it easily accessible? Is it visible? Is it easy to decipher? Was the medical record accurate and up to date? That's clearly not in this case.
Do we have that list you're referring to?
No. It's my own, but I can share it.
Through Kate?
Both of the tools do have lists. The Candor tool, which is available on the ARC website, and the NPSF RCA squared.
They got RCA squared, right? Yes. So it's in there.
It's in an appendix. It's not my exact list, but there is a list.
I was just trying to, you referred to that we discussed, I was just trying to pull it up.
Yeah.
And where you'll see a lot of that is in the appendix of RCA squared.
And there's also an appendix in the Candor toolkit.
In the Candor.
The event review piece of the Candor toolkit has. So this is actually a subset of what's in those tools. There are even more questions in those tools. Were there barriers to communication, like language barriers or technology barriers? Was a handoff involved?
Where might have, it wasn't in this case, where might have been a big communication issue have been? And we're doing a lot of work around this. Where might have been a big communication issue, particularly with the patient, have been?
With the signing?
So imagine if the patient is hearing impaired or doesn't speak English, and how do you go about doing a procedure where you're going to be laying the bed flat, maybe a little Trendelenburg, they got to bear down, they got to do all that sort of stuff. That could have been a real important issue to do that. And again, that's why I like the comprehensiveness of that list.
Was the team familiar with each other? So in this case, we had that, and we've said maybe almost too much, but in other cases, sometimes people who don't know each other and are trying to work together as a team for the first time, that can be an issue. Was there an orientation or huddle before engaging in the work?
Yep.
And might that have brought some things to light?
Yep. And what might have got discussed in the huddle?
Expectations, and at that point, maybe the physician would have made it clear to the need you to hand me the gauze, whatever. And so maybe at the point where the page did come, if they had established how the nurse would be needed, that nurse could have prioritized and said, I got to finish this test first, I'll answer the page when I'm done. I mean, I don't know.
Well, and who else might you have had in that huddle?
Pa-
It's kind of what Kelly mentioned earlier. Who might else who you had in that huddle? It could be the nurse took care of the patient, it could be another physician, it could also be the resource charge nurse.
Right.
So this nurse would be able to say, hey, here's my pager. I'm now going to be in there with the physician, and I don't want to be interrupted. This thing's going off every 3 minutes. That is the kind of thing you could talk about in the huddle to make sure you're like any big procedure we do, that you're ready to go forward. Yeah, and absolutely, you bet.
Well, and
Really great
here's where I've mentioned before, I don't have a clinical background, so when I do these reviews, it allows me to ask dumb questions. I might even wonder, the fact that they were so familiar and liked each other so much, could it have come up that neither of them really knew what they were doing? I don't know, and I mentioned the not clinical part because I don't know how the interaction between a nurse and a physician would work, but if it's a junior physician and a nurse who gets along really well, might one of them have said, hey, I'm happy to help you, but I've never done one of these before. I don't know.
It might have come up, again, the tricky part was the resident at the time thought it was going to be a standard routine central line, which they had pulled out before. So they were annoyed that they were going to have to do it. They did not know that it was going to be as big as a freaking dialysis catheter.
When you do a real timeout, that all would come forth.
I would hope so, and that's why, and I think you're right. It's no huddle without a timeout. To really go through. Let's really go through. What are we doing here? What are we all prepared? What are the risks? What's going on? Yeah. Related to that. So I think that's really, really good, because it would often be, Kelly, a timeout that you would do where you'd really go through a checklist, and of course. Maybe what that would prompt from the nurses, wait a minute, we don't have a checklist. Yeah. Where, holy cow, good.
Next category is devices and equipment. Was a device involved? Could issues with that have contributed? Was all the necessary equipment available? Did the staff know where to find the equipment needed? Was it functioning properly? Were the preventive maintenance and testing up to date? Did the equipment or device have appropriate indicators or alarms? Doesn't really apply here. Were there features of the device that made it difficult for users to understand how to properly operate it? Also
not really there, but I do think there is an opportunity to standardize the equipment and the stuff you're going to need when you pull a line out. I think that was, if you want to put that in the bucket of equipment, and I think we push that piece there.
Okay, do we feel like we've come to consensus?
Anything else out there that you think caused or contributed to the outcome? Okay. So they can huddle up, talk about solutions.
Okay.
So at your tables, and I'll try to, do I have any tape or anything? Maybe I could tear these off and put them up there. So at your tables.
Wait, do you want me to talk about strength of solutions before?
Yeah, why don't you do that, and at their table they can
then
then talk about solutions.
Okay.
Yeah, no, that's great. Great.
So this is a figure from some research that some of my MedStar colleagues did, which basically shows sort of the effectiveness and sustainability of different different types of solutions. So, just demonstrates that institutional and IT structure and physical environment type solutions are much stronger, much more effective and sustainable than something like discipline or counseling or even training. So I was going to have a discussion, and we can maybe skip this in the interest of getting to solutions in our case. I wanted to sort of figure out, just to talk about what kind of solutions you guys have employed and how sustainable they are. But maybe I'll go straight into strong solutions include things like actual physical plant changes, getting a new device that has been usability tested, forcing functions, which we talked about before, simplifying your processes, standardizing your processes, standardizing your equipment, maybe going to one PCA pump throughout the whole hospital instead of having different pumps on different units, and then tangible involvement by your leadership. More immediate strength solutions include things like increasing the staffing or decreasing the workload, enhancing the software, maybe putting an allergy alert in your EHR or a drug-drug interaction, eliminating or reducing distractions, checklists, cognitive aids, job aids, eliminating look-alike and sound-alike. Maybe you don't store the look-alikes near each other. Standardized communication tools, so using readback of critical lab results or having like a standardized handoff communication tool that you use. This is the way our handoffs are going to be conducted. Enhanced documentation and communication, redundancy, where you would have maybe 2 nurses independently calculate a dose. Weaker actions, which you can use. Often they're better than nothing, and often they're good to use while you're waiting for your stronger actions to be implemented, because some of those take longer to be implemented. Double checks, warning signs, labels, new procedures, new policies, additional training, additional study of the problem, and then, depending on the circumstances, potentially discipline. So if you kind of keep those in mind, keep in mind what's a stronger, as we discuss solutions, keep in mind, let's try to do the stronger, more sustainable solutions and avoid the weaker solutions when we can.
So you want to have them at their tables.
Yeah, let's do
Talk
that.
amongst yourself. In the context of this, what solutions you might recommend. But here's what I really want you to do too, because we just did this yesterday with this case with a bunch of master's level nursing students and residents. And it was fascinating. For every solution proposed, people then talked about unintended consequences. So as you think about this, think about, can you really do this? In your organization, are these things where, you're able to move forward and do that part? What might be some of the unintended consequences? So why don't we have you spend some time at your tables, kind of work this stuff out, and then we'll report out and see.
Can people see these? Should we maybe put them up on a chair, or?
Can you guys see them, or should we put them higher?
Higher?
Higher.
Yes.
And they should have a slide of that in there.
And yeah, actually, it should be in the packet.
Yeah, that should be in one of the slides. There should be a section in there of stronger, intermediate, and.
But I'm happy to go back.
I think this is going to work. There we go. I think. All right.
That is so interesting.
Which one?
So standardizing equipment and processes.
Oh, yeah.
So you think about this. We only have 2 long-range refueling aircraft in the entire Air Force inventory. And across the entire DoD, just 2. It's a KC-10 and a KC-135. Those are how we refuel planes. How many medical pumps do you have that do the same type of job?
Even within the same hospital, you have multiple.
Right.
Yes.
Yeah.
This is such an interesting thing. And then, the leadership involvement piece. And this is where if you can get someone's supervisor to come in and say, hey, we made some mistakes here. What can we do to kind of
what a number of your comments, I didn't say it, and I've said it before. Human factors, aviation, military, and nuclear power are so much more mature than in healthcare.
Well, and part of ours, so think of those industries, they're all monopolies.
Yeah.
There's no market
And they're
competition.
regulated.
That's true.
They're,
And they're
regulated
regulated.
like crazy,
Like,
but there's
do it
also
or we shut you
there's
down.
also no competition. There's none of that part. So when you're in a $1 trillion healthcare industry, and I think I've got a better mousetrap,
Oh, yeah.
I can bring it out there, and then so you may have an organization that has all these different pumps,
Yeah.
all this different stuff. In this case, where you're going to need the leadership, I'll be interested if they come up in it, is who's going to say, we're going to make sure that people pull lines out are competent, they're well trained, they've demonstrated it in simulation in other places, and we're going to make it easy for the doctors and the nurses to know who are the doctors and nurses competent to do this. I mean, that requires some serious.
The hard part is then how do you go back and check that? So normally what we do, we go back to a folder training file that says you've been checked off competent.
Yep.
You've been reviewed multiple times. You've had
Yep.
to be recertified.
Yep.
So what doctor's going to want you to do that? When they go back and look at the record, say, hey, you haven't been certified in 14 years.
That's right. Well, so we do it, though. Where we do it really well is in privileging, for example, for surgical procedures. So the OR scheduler will often go right into that database and go, wait a minute, Dr. Coffey is booking a lap chole? He's not privileged to do that. Call goes back to his surgical coordinator, say, not going to happen. So what they're trying to build now are apps that residents have to carry, junior physicians have to carry to show that. I've done 5, I've been supervised, I've been signed off, so when the nurse asks, say, yep, but it's right here. Yeah. Or the nurse has access to the app and goes into it and does that.
Interesting.
That's where the world's going,
Yeah.
to be able to do this in an easy way and using technology to help us out doing it so that the people who feel uncomfortable not doing these procedures, they have the answer. The problem, so what the problem at one organization was that, because this is a big problem in a lot of hospitals, is that a whole lot of residents would then opt out of ever pulling lines out. This is awesome. I get called. I'm just going to say, I'm not competent. It's not on my list. And then you have trouble finding people to do it. So one of the hospitals, this is yesterday, this one master's prepared nurse said the nurses ended up pulling the lines out because they couldn't find physicians to do it. So the nurses went through a competency. They had to go up for pulling the lines out, so they had to go through. So it'll be interesting to see, where they go, because a lot of times there's these unintended consequences of, hey, this is how you imagine it, but really, is that going to happen? Are you really going to be able to do some of this stuff?
Yeah.
So it'll be interesting to see what they come up with. How much time, Kelly, do you want them to give?
What time is it?
Another 10 minutes?
Sure.
Take a half an hour, debrief with them, pull it out, back and forth. And then I'll write down solutions as they come through. In the real deal, it was a big deal, and we actually did have whole departments opt out of pulling lines out. Which one one department you think really opted out? Said, we're not doing it. We're not going to train our residents, and we don't want you to ask them again.
Neurology?
Psychiatry and neurology.
Yeah.
They both opted out. One of the rules that got pushed back, and I talked to Dave Mayer about this, was for interventional radiology that gets paid a lot of money to put these in. You put it in, you got to take it out, even on a weekend, because you're getting paid for doing this stuff. And that took so much of that bottom thing right there, So it's going to be, I'm really glad you have this slide up, because we should be able to, talk through some of them with that.
I can imagine the pushback they'd have gotten. I got to come all the way and scrub a big raise, pull a line out, it's going to take me 30
Yep.
seconds.
So their workaround was, which got approved, so it's not really a workaround, is what's another thing that could have been done with this patient related to inappropriate So, who's got the coolest solution?
Nobody has a cool solution?
Do you guys have a cool solution? How about this table here? What are just some of your solutions?
Ours really hinges on a protocol and the elements of the protocol. I mean, we buried a lot of it in the protocol. So the
Okay.
equipment that would be needed, where the procedure could and couldn't be done, who could and couldn't be done, and the whole piece around training and competency, including use of a checklist. And we thought if there was a way to even embed in the EMR a hard stop, so you couldn't proceed until like all the elements of the checklist were completed. And how do you call out, that you need to review the the record of the patient before you do the procedure? I'm not quite sure how you get at that.
Do you want a suggestion for that?
Yeah,
It's part of the timeout.
yeah.
So there should
Yeah.
be a check
Have
on
we
the
looked at all
timeout.
the necessary
Do we have
documents?
an
Right.
up-to-date EMR? Do we have all the
Right.
information that we
Right.
need? And do we have the most recent information from the last location where the patient was?
Yeah.
So that is, some people will put that into their checklist.
The other thing we were really wondering about is this whole area around
So-
handoff and where all the important handoffs were missed.
Right.
And, yeah, we want
So
to know where the primary
so let me see,
source-
I want to get this right. So your big solution, which I totally agree with, and I'll let Kelly weigh in. Kelly, what do you think about developing a protocol for pulling lines?
I think it's a great idea. I think it has to be developed with input from the people who would implement it,
Exactly.
so that you know it's a
The
workable
people closest to the work. So,
protocol.
yeah.
Yep.
Yeah.
So that's
It
where.
can't be a policy from down on high.
So that's where that group that Kelly mentioned, remember, who did she mention should be on the group besides having a patient advocate on it?
Someone else familiar but not involved.
Exactly. So in this case, it would be whoever you would identify in the organization are going to pull lines out, need to be building that protocol. So who are some of the people in that organization you would have part of building that? Which kind of physicians? If you have residents, it would be great. If you don't, interventional radiology, who else?
Surgeons.
Maybe dialysis, although they're just machine people. They're not. Who else in the hospital who we really trust pulling lines out?
Trauma surgeons. or
So
general
surgeons, absolutely surgeons, interventional radiology. Who is another group? Hospitalists, particularly those who may work in the ICU, that do this. And you want nurses on that group, right? To be able to do that. And I think that's the key, Kelly. Explain why that, and frontline people, why that's so important. What you're about, who's going to be part of building that protocol.
Well, just because you need it to work for them. You need their perspective. If they're involved from the beginning, they can tell you that won't work, or that's not how we do things, or it's not consistent. That's not how we do things as like in a bad attitude, that's not how we do things, but just let me tell you why this won't work.
We had a bit of a discussion that even if we had the best protocol ever, in this situation, we were lacking communication or handoff, so that we thought that it was fairly clear that neither the nurse nor the physician understood when they entered the room that they were going to be pulling a dialysis catheter. We kind of thought maybe they were just going to pull a general central line, which
Right.
is probably similar but not the same.
So where does that fit? So agree, that's kind of in there. What would your solution be to that?
Effective handoffs.
Right. Yep. So I want to go back to the protocol piece as well, and this comes again from what Kelly said. How would you monitor, once you get this protocol, what do you then do with protocols in your organization? I mean, it's in a file somewhere, right? So you have the protocol, then what do you do?
Share them, make them accessible.
So you need an education plan, right, too. That's a huge piece. We often write really good protocols, and then we don't push it out to the organization. How do you guys do that in a reliable way? This was really important. So how would you, because doesn't pretty much everybody agree the protocol is a really good idea? How would you push it out in all your different organizations? Right. So I would agree. I don't know about you, Kelly. Memos and emails. This goes back to alerts. I could put in that email, if you read this email, call me for $20, and I'm sure I could send out 1,000, and only a couple people would call me. I would agree.
Yeah. So, well,
How do you guys do it?
In the ER, there's a board where the physicians usually do their dictating, and it's just your standard court board, and we have them placed there. We have one, for example, for migraines, and then we have our stroke protocol. We have a TPA contraindication indication list. So it's just one more protocol that we can use. I think it's always a good idea. You look back now, we have a new one recently for eclampsia, which we hadn't thought about until we had a lady that was pretty severely eclamptic. So just splaying it out there for people to see. And you'll be surprised, physicians will sit there waiting for a lab result, and then they'll see it and they'll kind of glance at a few things. You'll be surprised how much they remember just by having it there glanced at every once in a while.
Great. Other ways that, yeah.
Well, I guess not specific, but just a general comment.
Ah, she got two. That's a systems issue. We have a lack of clarity of who to throw to you.
Just the repetition, so everybody obviously listens to things different, picks up differently, learns differently. So you have to do it, I think there's not just one way. It should be done several different ways to communicate.
Oh, to communicate. Oh, I
Yeah, to
absolutely agree.
communicate.
Yeah.
We
So
have to
let's keep
educate
tossing
on
some
it.
of those out because I'm
Yeah,
really
we-
interested in.
We've had some success with skills fairs, so we literally walk people through it in action with people watching and giving feedback as they do it. The challenge with that is oftentimes to set that up, it takes some time, so it's not like a quick and easy, but you can do that one-on-one. We've done that before with staff as they come in for something critical to say, okay, we're doing a skills fair on the front end of the shift, and we'll get that practice in. So that's an option. And tracers, so after that's implemented, just
Yep,
go
that was
trace
good.
it later and watch it and observe it and give input.
Yep. I love the idea of those. And you bring your sheet with you, if I remember correctly, and you get checked off. It's kind of an annual thing. Here are the things the organization has prioritized that I need to demonstrate that I understand this protocol piece. That's good.
So so our nurse managers will do the training,
Mm-hmm.
and then they'll follow up like in their daily huddles. So remember this protocol.
I was wondering about huddles, yeah.
Yep, review the last 5 minutes, review a protocol. And then also our policy software system has an acknowledgement thing on there so they can send out a protocol in there that'll send the nurse an email to say, hey, you need to review this. And then they can kind of track who's reviewed and kind of signed off on it as well. So they kind of use those methods.
So how would you measure whether or not this amazing protocol that got put together with all the great stakeholders, you've had a way to push it out to the organization where both docs and nurses have been able to go through this and demonstrate competency, maybe in a sim lab, or maybe during one of the fairs. We have a mannequin and people really have to show it. How do you now monitor its success? That it's working, that they're doing it?
We oftentimes throw it out as a huddle metric, for a department or a unit if it's something new, and then evaluate effectiveness with the staff at change of shift huddles. We also do tracers, like you mentioned, so we're retrospectively looking.
How many of the checks did they get? Did they get 100%, 50%?
Yeah. How did you do it? Because it's been really ubiquitous now. Monitor following the central line bundles and putting lines in. How did you guys measure that compliance and that you were?
You do it by direct observation, or you do it after the fact, retrospectively in the chart audit?
Right. So fortunately with EMRs, you should be able to go through and look and see how many people got a central line, how many got a dialysis catheter. You should be able to pull those charts up retrospectively and look and see, is there a signed protocol, a checklist protocol in the chart? And if not, what do you do? You got to circle back, and you got to get down into the tunnel and say, hey, why this, why not that? So this was a big deal for our organization, building that protocol out. It took forever to come up with a standardized process because you had surgeons, interventional radiologists, ICU docs. It's kind of like putting lines in initially. They all were doing it differently. It was a really, really huge struggle. Fortunately, these big cases, sadly, it takes them to create a sense of urgency where we kept bringing it back especially when you bring the family back to encourage you to keep doing this, it kind of drives a bit of that urgency. Other solutions for others. So that's a big one. Anybody address any of the other stuff?
How about competency? Did anybody come up with anything or is that all part of your protocol, that if you have the protocol, anyone can do it given the protocol? What were you thinking about that?
We were thinking that regardless of how much you assess competency, you will always come across a task that you've never performed before, and yet under the circumstances, you just need to move ahead and perform it. And so if the checklist or the protocol is clear enough and effective enough, that really can be your just-in-time training as long as you're following the steps of that.
Mm-hmm. Do you think organizations should have lists of things, though, where you can ask a person whether or not they're competent to do it and create that list?
I think that we can. And I think for providers, we call that like a privileging list.
That's right.
We don't necessarily have one of those for nurses. I think that we potentially could.
Mm-hmm.
The difficulty of that is, even though you may not be credentialed or privileged, you probably wouldn't be privileged down to the level of pulling out a central line.
Yep, it's a
that just-
competency. I agree
mean, that
with
just
you.
goes
Yep.
kind of, you have to be practical.
Mm-hmm.
And the list can't be 500 pages long,
Mhm.
so.
Right.
Also, fine line, at some point, people have to learn. And so
Yep.
in our we don't have, for intubation, we don't have a formal protocol. The physician usually takes the first crack at it, and I give it 2 tries. If I can't get it, then I have the EMT try.
Mhm.
But sometimes some docs just say, let the EMTs do it. So we don't really have, I don't think, a formal process. But, everybody has to try at some point just to get like an IO, for example. Nurses will sometimes try, or I'll try, but we all kind of take turns, and I think it's important to do that. So, I don't know. It's just part of training and learning and getting your feet wet.
Yeah, so I would like Stephen to maybe weigh in this a little bit. So from the patient and family perspective, it's often very difficult to think about, you may practice on my loved one because you need to learn to do this. No, I'd like you to, because this is where we are now that we're bringing patients and families at it. I completely agree with you. I think we have a solution to that, but Stephen, I'd like you to reflect on that, because I think that's really an important place where we are.
So the thing that you got to realize is that I know when I talk to the residents that are coming to see my son that you're learning. I know the first year, second year, third year residents, and the interesting part is, having been at Georgetown for so long, I've seen an entire class go through. I know that you're there to learn. What makes me have comfort in your learning, and the fact that you've made some mistakes, and I've seen those mistakes up close, is that you tell me what's going on. And when you have those mistakes, and granted the ones we've had, as of recently, have not been catastrophic, but they're mistakes that were caught, and they told us what was going on. So the transparency is what allows me as a parent of a patient, or of a patient, to say, I know your doctor's practicing medicine. Words have meaning. So that's where it is. It's really about transparency, and understanding that there's a higher calling here, that what you're doing is helping out this greater cause of someone else. So maybe that goes back to the military training, that it's all about the big team effort. And so when you're doing things with my son, as we've gone through this road of galactosemia, as we've gone through this road of transplant, you're helping to refine processes that are going to impact a greater population. But the biggest thing is the transparency, though.
Yep. So I think you mentioned it, and I think this kind of even gets to the heart of that, is the issue of informed consent. In other words, we had this conversation just yesterday with the residents. It was awesome to talk to the resident physicians, the medical students, and the nurses. Was, if you're doing a procedure for the first time, do you tell that to the patient? This first time, I've never pulled this line out before. I'm just letting you know, I haven't pulled it out before. And that's transparency. And so the hope would be, this is where we're kind of going with simulations, say, I have pulled out a bunch of lines in simulation. I have done a whole lot of this stuff. I'm comfortable to do it, and I'm going to have a nurse who's going to be with me, who's pulled out a boatload of these.
So the thing that
And so that you're really, trying to think through all this complex, it's because it's complicated.
Well, so when you think about this transparency piece, I am much more comfortable with someone saying, I've gone through this in simulation, I've done this a lot of times, I've got somebody here to back me up. Because everybody has to start somewhere, right? I know this. When I talk about that second lieutenant that comes in the military, you've got to start somewhere because you don't just wake up and know. I'll give you the example. When I became a commander, I had 600 people that worked for me. 600 folks, 600 personalities, 600 personal problems. And I told my folks and my senior staff, I've got to grow into being the commander. Just because I'm a colonel, just because I've got this title, this pin that says you're the boss, I've got to grow into this. And so that's one of the things that you got to be transparent with, and especially when you're dealing with families. We know that everybody's got to grow. We want you to be experienced, but I want you to tell me. So if you don't have that confidence to do it by yourself and you haven't done those simulations, let me know. Because then I'll kind of be a little more understanding if something goes on and I think that you have this oogobs of experience, I'm more critical. Because you didn't tell me, hey, I'm still kind of new at this.
Yeah, so again, great conversation. I just want to get it out, because as you develop a protocol, if you identify who are those people to do it, what we ended up doing at the U of I was, to be a learner or even a faculty person, you had to go through simulation with a nurse who was competent doing it to demonstrate that you could follow the checklist, you were able to do it, and that's what it was. And, but what's the unintended consequence of that? Where you need to look at the bottom thing on the slide here. What's the consequence of saying you're going to have to go through training, we're going to have to do this piece and the rest of it? Well, you got to hold them to it. It's time is money. And so that's where Kelly's last one there. Do you want to speak a little bit of that to Kelly? Because that is super important and is a big deal at MedStar, from that part.
Right, so leadership has to be supportive both from a culture perspective. It has to be clear that this is a priority and that we're serious when we say we're going to improve safety. But also, as you were saying, time is money. You have to make people allow them the availability to get the training and to and then have some consequences if you're not. If the solution is not being implemented, make it clear that it's a priority for leadership.
Yep. So when you build a protocol and it gets approved, I don't know how you would do it, but it might be through the nursing council or whatever you have, as well as through maybe a medical executive committee. It's got to make its way up where people can agree to it. Part of the conversation you need to have in that room is going to be, okay, here's the deal. We built this. Do you have our backs? Because, boy, there's nothing worse than you put that out there, and then, people don't want to be held accountable to it, and then you start getting the workaround from the sacred cows in the hospital, and now you just destroy the culture. Because now you've clearly developed the two different standards of behavior and the rest of that. So that's why I love that last one. And so when you think about the solutions, what's it going to look like, and what are you going to do if people don't play? If they don't go by, or you do an audit and it's, certain people aren't beginning to do it. So I think that's really good. So we got the protocol piece. We've addressed a bit of the competency part. Hopefully the procedural clarity would be there. Anything else in here that you guys thought you might want to put into place as a potential solution? Yeah.
Does the nursing and medical staff administration need to make some decisions about what they're going to assign to residents and where they're going to allow procedures?
So kind of the who and, what did I write? Who and where.
Absolutely.
Right. They
So
need to
that
come to
is a
consensus.
big honking deal. Do you have residents?
Not at our hospital.
Do anybody in here have residents who rotate through it all? So the way it works with residents is there's this entity called ACGME, the Accreditation Council for Graduate Medical Education. All the places that have residents have offices of GME. They're the ones that oversee the residents who work with the nurses and medical staff to come up with this. So in our organization, that was a big, huge thing because we have, I don't know, how many residencies does Georgetown have? I mean, U of I had with 38. 38 program directors. So think of in medicine, it's medicine, but then it's cardiology, nephrology, infectious disease. All those are residencies or fellowships. That was a huge bit of communication in our organization as it was at MedStar with Georgetown and the rest of it. It's a really big deal. But tell me about the location piece. What would, again, be, we talked a little bit about it, what would be, again, a potential solution so that this would not happen again? So if IR puts it in, they take it out. That's one. What's another? So that's one, and you need IR to agree to that. Stephen and I just had a conversation about that. What if it's 4 o'clock in the morning and it needs to come out and it's a Saturday?
We could consider a procedural room in each unit or on each floor or something like that.
Yeah. Where's another way that you could flip on that would be in the ICU. In other words, if IR isn't around, isn't going to come in, they need to get somebody else to pull it out, and it needs to be in a place like the ICU or someplace else to do that, where you have monitoring and you have the ability to do that part. That solved our problem right away, because we made it a blanket process. We will not ever pull out dialysis catheters, except in these very specific locations who have the right people, the right place, the right equipment, the right ability to do it, to monitor and have backup and the rest of it. So that was it took a long time to get people to agree to that. But
and that's where the leadership, again, becomes so important.
Right.
When you were saying before, if you could get IR to agree to that, in my head I was thinking, if the leadership says this is how we're going to do it, and then stands behind it.
One point on leadership, and this is, someone posed the question earlier about how do you change the culture, right? And that's when we get to the root cause of how we make Candor a part of what we do, our standard operating procedures, SOPs, it's how do you change that culture, and it really comes back to the leadership involvement. And so I can say for the years that I've been on the Georgetown PFAC and what I've seen at MedStar writ large, it's because we've had superior support from folks like Dave Mayer and folks like Lisa Boyle, who have said, this is important to us. And because those guys have stepped up in their roles, and I know they're super busy, have stepped up and said, this is important, it trickles down to the people that are actually thinking outside of the box and sometimes thinking inside the box to make these things happen, to put these safeguards in place. So the biggest appeal, if you're trying to change the culture, you got to talk to the leadership. And the leadership has to buy into that, and the culture will start to change because it gives you the comfort and the assurance that I can do something that's maybe not standard. And I can present something, and I can say that I'm not comfortable doing this, and I'm not going to be shunned or castigated or anything like that. No scarlet letter for me, because leadership says it's okay. That's our culture that we've changed to make addressing problems, making an inability of having experience not a problem anymore.
Yeah, that's great. So one of the other pieces that got mentioned a lot, you were going to ask more questions about it. I think it went in the parking lot. Staffing ratios, production pressures, and all that. How do you deal with that? Everybody agrees it is a contributory cause to stuff that happens in the organization. And remember, the other beauty of looking at these is this applies not just to pulling lines out. One of the things we really enjoy in doing these really deep dive event reviews is think about all the other procedures that it's an opportunity before somebody gets hurt to think about, well, can we expand this possibly beyond just pulling out central lines? But how do you manage, I'm just curious how you manage production pressures, staffing issues. Everywhere I go, it's there's less reimbursement. We're asked to do more with less. To do all that, how do you, I see it as a cause. Has anybody had any solutions or ideas about how you can generate any solutions around it? God, I'm seeing a lot of blank spaces.
$500,000 question.
What's that?
The $500,000.
$500 billion. No, really, it is a really huge issue, right? Kelly, have you encountered this? Have you seen any solutions that are related to that? Because it's everywhere. It's in the ED, it's in the operating room. You think about, I don't know how your EDs are, but we board patients there, and then we board more and more and more and more, and throughput's a problem and all that. What have you seen
I have
any
not.
solutions yet?
I have not. I will just say it's in primary care. It is everywhere.
Yeah. And I don't, go ahead.
I'm curious to hear the answer too. We're just going through it where we have an average daily census between 7 and 8. But the day that you're at 19, the ED has a trauma. We've got a mental health suicidal patient who is threatening murder. So we've got a one-on-one watching that patient in the ED who's been there for 2 days. Staff are stretched by that. And so how do you even say to them, get used to that once in a while? Is that even okay? Because that stresses them for a period of days, even though the census might come down after, and then it happens again a week later or 2 weeks later. That's the challenge and fiscally, how do you get through that? So that is the billion-dollar question. We're challenged with that as well.
Well, so I guess that I would say that as long as we know that's a continuing problem, it becomes that much more important to have the strong systems, the standardized processes, the devices that actually work for people instead of working against them, the other things that we can control.
So, Stephen, you have any ideas with that? Because you have to have had to deal with production pressures all the time. When you guys got to ramp up and there's crazy engagements and stuff going on.
I'll tell you from a military perspective, because we have this, and I set the stage because when we started with Operation Enduring Freedom and Iraqi Freedom, so that's Afghanistan and Iraq, we had a problem with people, had a problem getting people in. And what it came down to, and again, this is a military thing, so we can try to break it apart and see how we can apply it to medicine. We had to prioritize. And that's a really tough thing to do when everything is a number one priority, then nothing is a number one priority. And so it required us to say we've got to change our mindset with regard to what our operational battle tempo is. We went through a surge period of working longer days, which is a little hard for you guys because you're 12-hour days already, right? So it was a little more difficult that way. But it became making some creative solutions to addressing problems. It was, we got more chaplains on staff. So when we talk about the suicidal thing, I mean, there's a mental health, and you are probably more aware of this than probably I am as well, is a real challenge that we have to deal with in the military. And it is not something that I've got the answer to, so sorry to disappoint you on this one. But it's a serious problem, and we're trying to address that by saying, hey, we need more chaplains, we need more doctors to come in and help us do those things. But the biggest thing that I would tell you, if I had to try to pinpoint an answer, is that we've got to make the priorities. So how do you tell your staff, this is what our focus is? It's changing the priority, and that comes from leadership.
That's where I was going to go. So in my world, and it's like this case that happened, where I'm sure we hurt a lot of people, with pulling lines out and the rest of it. Just this case was so obvious, so big. We did the interview. We learned what it was. We had this huge aha moment. At some point, as you gather all of these, what do you call them? Bits of data, points of data? Data points.
Data points. Yeah.
Data points. So data points are data points. Tomato, tomato. But no, you get all this data of these things happen, and that's where often you can use your patient advocates. You got to go to the board. In some place, if this is because you need more money to be able to do this, you have to do what, have you ever heard, Candor wrote, the most famous article in the Harvard Business Review about change management. What's the first thing you need to do if you want to change something and have it be sustainable? You got to create a sense of urgency. Mm-hmm. It's what the IOM report to Eris Human did. It created a sense of urgency in the country around patient safety. The metaphor that was used in every newspaper at that time was what? To describe how many patients die every day from preventable medical error. Yeah. What was the metaphor used in the newspaper at that time to create the urgency? Fits with aviation. Equal to a 747 going down every single day. That was in every newspaper when the IOM report came out, to create this sense of urgency. If this is an ongoing issue, the production pressures, the staffing issues, you're just getting beat up. At some point, you get enough data points of harm that's happening and the rest of it, to get it to the group that at the end of the day is one that has to make the priority decision about, are we going to buy 2 more robots for our OR, or are we going to hire, more nurses in this area to be able to, you've got to make, but you've got to call the question. And so one of the things you can do is bring to the leadership and the board, here are our issues, and that's where a really good event review is super helpful, because you're bringing the data back, you're bringing the case back, but you're also bringing the patient and the family back. You're bringing their story back. Part of why we start with Stephen is to connect your heart with your head. And at some point, you've got to be able to do that. But I don't know places that have really cracked that nut yet. I mean, I've seen improvements in some areas, but people have gotten smarter about how they measure it, acuity, plus all those little measurements and stuff you have out there. But unfortunately, don't have the solution.
But I think one of the things that's important is, as you said, bringing back data, right? So when we were doing OIF, OEF, we didn't do autopsies in the military. I was like, whoa, what? No, we didn't do autopsies in the military really heavily until after 2004. We started in 2002 to do a little, but 2004. And the reason why, and what we found out after doing autopsies, was that we needed to reinforce our body armor, because when we give you a flak jacket, it covers the front and the back, but it doesn't cover the sides. And we saw that a lot of people were dying from wounds on the sides, right? So the way that changed, the way that priority changed, is that we had data. So the event review process, having a detailed process, there's your data. And so the other part is that you have to understand that once you connect your heart and your head, you have to also talk to people at the level that they're interested in. And so I used to tell folks all the time, there's a certain threshold of pain. And I don't mean that in a negative sense, but for example, when I have airmen, I say, hey, you're either going to be motivated by time off, awards, and decorations, or promotion. And so I've got to affect one of those things. Well, in a hospital, you're generally affected by a bottom line of money. Remember when I started off earlier, I said, remember, medicine is a people business, but it also still is a business. So how do I help you turn people out of bed sooner? How do I provide better care? I bring you data, and I say, this is why this is important. This is why we need to put more emphasis on mental health, more emphasis on this, more emphasis on that, because it's going to not only help your bottom line, but it's going to make us a better hospital. And that's what you do. You got to have your data, though.
Thank you. So, is Kate in here? Would they be ready if we did a break now? Is there stuff out there for that? Because, I mean, this is intense stuff. I think maybe what we'll do now is let's take a 15-minute break. Then when you come back in, just gather at your table. And I'm going to have, for those of you at the last workshop, I'm just going to go through this very quickly, and we'll come back to some of this piece. We want you to huddle up and think about the big 3. Because you're going to have the sons, you got to communicate, and you now know all of what we talked about. And remember, the slide that we want you at your tables to talk through is this one, because this is super important. This is connecting now event review all the way back to the communication piece with an eye again towards resolution. So they're going to be up here. You really need to think through, just like we did in the last workshop, what are the goals of this interaction going to be? And remember, this is a planned meeting. You'd already told them, you already had the communication with the husband before they left, or the son, before they left. Hey, we want to reach out to you and do that. It's a couple months later. You've reached out, and the sons have said, yeah, we'd love to talk to you. The funeral's over. We'd love to talk to you. What's there. And then you get to identify who are going to be the 1, 2, or 3 people you want to have in this conversation. And then you're going to need to role play it. Like if it is your hospital, now that you know what you know, really, who would you have, for that conversation? What questions do you anticipate? That's a really good one. Talk about your table. And how are you going to answer them? What are you going to say when they ask the certain kinds of questions? And then the emotions, again, like Stephen said, there's going to be some emotions. How do you validate them? How do you not minimize them? How do you not take them away from feeling the way they're going to feel when you share this information with them? Being there with them. And then what are you going to share, discuss? And then obviously we talked about responding to the caregivers, but practice at your tables a little bit of this, coach each other. But let's take a break first, and then spend plenty of your time at your tables working with each other, and then we'll come up and then we'll have this conversation. And Kelly and I will walk around to the different tables, and even Stephen, to help you with that. I'll maybe throw you some questions and say, hey, how would you go with it? Is that cool? Does that make sense? All right, let's take a break, and we'll see you soon.